I'm very glad to introduce a friend of mine, Dr. Thiago. He's a Brazilian nephrologist, but he has a huge formation. He's a researcher at Laboratory of Molecular Pharmacology of University of Brasilia, Brazil. He's a senior physician at the Department of Kidney Transplantation in the Clinic of Doencas Renais de Brasilia. And he's a research affiliate at the International Renal Research Institute of Vicenza, along with, of course, Dr. Claudio Ronco. Welcome, Dr. Thiago. It's an honor to be over here with you.
Thank you, Rubens. Hello, everyone. I'd like to thank Nova Biomedical for organizing this session. These are my conflict of interest. So we know that citrate chelates cations. So we use for anticoagulation sodium citrate, and we know that citrate chelates calcium and hinders the coagulation cascade, but also another divalent ion, which is magnesium. So we have it complex also with magnesium. This is the most important trial about citrate anticoagulation and the comparison between citrate versus heparin in CRRT. And it was demonstrated that here in the horizontal line we have time after treatment commencement, and here in the vertical line we have the future lifespan. And it was demonstrated clearly that with citrate we have a better lifespan, so 47 hours against 26 hours with heparin. And more important than that, there's less bleeding events, so 5% for citrate and 70% for heparin. We know citrate is safe, only 30 minutes, it's half-life, so within 30 minutes, citrate and ionized calcium and magnesium return to normal levels. Regarding citrate accumulation, we know that severe and sustained hyperlactatemia is associated with accumulation, but it's low, only 6%. And when patients don't have hyperlactatemia or it's not sustained, it's less than 3%. Citrate can also be used in patients with active bleeding because it only has this property to block the coagulation cascade when the concentration is below 0.4, and this is not compatible with life. So within the future, we reach those concentrations of ionized calcium, but not in the systemic coagulation. And this is a blueprint of the circuit. So imagine the blood is coming from left to right, and here we got citrate in the circuit, and before it we measure ionized calcium. Then there is the blood pump, the dialyzer, and here we measure the post-filter ionized calcium, and here is the calcium compensation. Usually we perform this test every 6 hours, so 4 a.m., 10 a.m., 4 p.m., and 10 p.m. And now this is the screen of the machine. So again, blooding coming from left to right. So we have citrate getting in the circuit right here. We have the blood pump, we have the dialyzer, we have the dialysate, and then the blood goes to the warmer, and then bubble trap. Here in the bubble trap, we get replacement solution, and finally, calcium compensation. What's important here is that the solution that we use as anticoagulant does not have magnesium, does not have potassium, so this corresponds to 50% of the dialysis dose. See, the flow here is 1200 miles per hour, and the dialysis flow is the same, 1200 miles per hour. So the patient will be prone and probably develop hypophosphatemia, hypomagnesemia, and hypokalemia. And to estimate the concentration of any given solute that the patient will be exposed to, there is this weighted arithmetic mean. So in this case, for potassium, the concentration, the final concentration will be the concentration of potassium in the citrate solution times citrate flow, the concentration of potassium in dialysate times dialysate flow, and finally, the concentration of potassium in the replacement solution times replacement flow divided by all those flows together. And again, stressing this point here, this solution does not have magnesium, does not have potassium, so in this case, the patient will be exposed to a final concentration of potassium of only 2.5. Now, concerning magnesium, we know that 2/3 of magnesium, of the total magnesium, is ionized magnesium, and this is the active form of magnesium, and 1/3 is protein-bound or complexed as a salt, for example, with magnesium. So when we do citrate anticoagulation, at least 30% of magnesium gets bind to citrate, and we only have now 40% of those initial ionized magnesium available for its biological activity. This study was performed in Czech Republic using Prime Plus from Nova Biomedical. So again, the circuit here, citrate gets in, blood pump, dialyzer, and they measured ionized pre-filter calcium and ionized pre-filter magnesium, and also post-filter ionized calcium and magnesium. And they demonstrated that there was a linear correlation between ionized calcium and ionized magnesium. This was expected, both are divalent cations. The same was observed for the percentual reduction of ionized calcium, so the percentual reduction pre and post-filter for calcium and for magnesium. So here, for example, we have a reduction of 68% in ionized calcium pre and post-filter, and if you go here, it's the same for magnesium, 68% of reduction. Again, to estimate the concentration of magnesium that the patient will be exposed to, we do that formula, and as this solution here does not have magnesium, so we estimate that the total magnesium concentration that the patient will be exposed to is only 0.42. The normal total magnesium is 0.7521. So the patient likely, probably will develop hypomagnesemia. In another trial, it was demonstrated that there is a linear correlation between total magnesium and ionized magnesium in critically ill patients. However, this does not occur in patients undergoing CRRT with regional citrate anticoagulation. So this is that trial. It was performed in Holland, 92 patients. And here in the x-axis, we have total magnesium concentration. And here in the y-axis, we have ionized magnesium concentration. Again, this trial utilized Prime Plus from Nova. So the circles here represent patients not on CRRT. So we can see that when the total magnesium is in the normal range for those circles, the ionized magnesium will also be in the normal range. So we have this linear correlation. So if the patient has total magnesium concentration in the normal range, we can assume that that would be the same for ionized magnesium. Nonetheless, the squares represent patients on CRRT with citrate. So this darker area represents the normal values. And we can see here in the squares that we think that those patients have normal magnesium concentration because total magnesium concentration is in the normal range. However, if you go here, you see that for all those patients, all those measurements here, the ionized magnesium concentration is below the normal range. So we are assuming these patients are doing well and they are normal, but in reality, they have lower concentrations of the biological form of magnesium. And this was just published last week. It was a study performed in Thailand, aiming to study the kinetics of citrate during CRRT, but the point here was in patients with acute liver failure or acute on chronic liver failure. Here in the horizontal line, we have the time after treatment initiation, and in the y-axis, we have the concentration, in this case, of ionized magnesium. So here from baseline, we see that patients with acute liver failure have a slightly higher concentration of ionized magnesium when compared to patients with acute and chronic liver failure. The therapy starts, we expect to have a reduction in ionized magnesium because of citrate. Then after 2 hours, the treatment with citrate was stopped, but the CRRT session continued. And as expected, we see that after like 60 minutes or 2 hours, there is a return to baseline in the concentrations of ionized magnesium. I've showed you in the beginning, it took like 30 minutes, but we need to remember here that those patients, they have liver impairment. This study was conducted in Brazil with 232 patients, critically ill. It was an observational trial. And in this trial, the total magnesium concentration was measured. So 118 patients developed AKI, and 114 did not develop AKI. And regarding ionized magnesium, so 47 of those patients that developed AKI had hypomagnesemia, and 62 in those patients with no AKI had hypomagnesemia. Here it's the universe of those patients that had AKI. So in the group of patients that recovered from AKI, 31% had hypomagnesemia. However, it's important here that those patients that had persistent AKI, 70% of them had hypomagnesemia. This other study was conducted in Belgium with 400 individuals critically ill. It was also observational. And at ICU admission, 14% had hypermagnesemia, 68% normal ionized magnesium levels, and 18% hypomagnesemia. From those patients that developed hypomagnesemia during their stay in the ICU, those patients had a higher Apache score, higher SOFA score, were more prone to have septic shock, have longer ICU stays, and a higher mortality. Again, we need to be cautious with our conclusions because we know that correlation is not causation. So imagine if this cat is hypomagnesemia and this column here is AKI. I don't think we can claim that the cat did this, right? So those trials were observational. No interventions were carried out to correct hypomagnesemia, but this needs to be further studies to see if there is actually a causation of hypomagnesemia and worse outcomes. So the point-of-care analyzer in CRRT allows the identification of ionized hypomagnesemia. We don't see this because we only measure in our routine clinical practice total magnesium. With the point-of-care analyzer, we have fewer time periods of CRRT circuit ionized calcium above 0.35. So we can, in 1 minute, instead of like 2 hours, correct the citrate infusion. Usually labs take like 1 hour to give you back those results. So here we only need 1 minute. And if we are working with the right ionized calcium concentration in the future, we assume we will have a prolonged circuit patency. We will also have fewer time periods of CRRT circuit ionized calcium below 0.25. And we don't need to work with an ionized calcium concentration below 0.25. Below 0.35, it's enough. So this means that we will have less citrate consumption and less citrate wasting, which is a really expensive resource. And also timely correction of hypomagnesemia, hypoionized calcemia, potassium disorders, sodium disorders, and also bicarb disorders. Okay, so with this, I thank you, and let's move forward.